Hi, my name is David Cucchiari. I'm a transplant nephrologist from the hospital Clínic of Barcelona. And today I will talk about neoplasia in kidney transplant recipients. So let's start with epidemiology. So we know that renal transplant recipients have at least a 2 to 4-fold increase in malignancy compared to general population, and it is the second cause of death after cardiovascular events in this population. And the increase in the incidence compared to the general population can vary according to different factors. These factors include the type of tumor, age and sex, geographic factors, and ethnicity. So regarding type of tumor, it is very interesting that there are some kinds of cancers that are very, very common in kidney transplant recipients. For example, non-melanoma skin cancer, lip cancer, typical cancer of smokers, oropharyngeal and Kaposi sarcoma, whose standard incidence ratio is 20 times higher in kidney transplant population than in general population. And other cancers that are very common in transplant population are urogenital cancer, post-transplant lymphoproliferative disease, thyroid, and neuroendocrine cancers. Less common cancers are colorectal melanoma and cancer whose incidence is more or less similar to that of the general population are cancers such as that of prostate, lung, pancreas, breast, and uterine. So, for example, these big killers in general population, well, they are not so common in kidney transplant population. Age and sex, of course, they can influence the development of cancer in our patients. And this is especially true for young patients. Look at the relative risk. The relative risk is higher in all ages, but this is especially higher for patients whose age is 44 years old or less. So let's move to risk factors. Risk factors include, as I have just said, patient age and sex, sun exposure, of course, previous malignancy before transplantation increases the risk of another malignancy after transplantation. Risk factors in the general population, such as smoking, obesity, diabetes mellitus, they increase the risk for neoplasia after transplantation, and these are risk factors that are specific to the transplant population, that are viral infection, type and intensity of immunosuppression, and the duration of dialysis before transplantation. So talking about viral infection, we know that different viruses are implicated in the development of these cancers. For example, Epstein-Barr virus. It's especially implicated in post-transplant lymphoproliferative disorders, whose incidence is very high in kidney transplant recipients, and outcomes are much worse than in general population. Human herpes virus 8 is associated especially with Kaposi sarcoma, which is very, very uncommon in normal population, but it can be found in our patients. Human papillomavirus is associated with skin cancers and urogenital cancers. Skin cancer, it is interesting that many skin cancer, apart from being induced by exposure to ultraviolet radiations, in many cases, skin cancer cells contain the genome of HPV. And of course, HPV is also implicated in head and neck cancers. Of course, hepatitis B and C viruses are associated with hepatocellular carcinoma, and another skin cancer, Merkel cell carcinoma, is associated with this polyomavirus. Regarding type and intensity of immunosuppression, we know that anti-lymphocyte globulins are strongly associated with the development of post-transplant lymphoproliferative disease, while basiliximab anti-CD25 antibodies are not associated. There is an association between rejection, CPRA, and HLA-DR mismatches with the development of neoplasia. So this means that the treatment of rejection is not for free. patients pay the price in terms of an increased risk of malignancy after the treatment of rejection. So also for this reason, it's very important to avoid the development of rejection. And moving from induction to baseline immunosuppression, we know the carcinogenicity of calcineurin inhibitors. We will talk about it in more detail later. Regarding antimetabolites, we know that azathioprine is more carcinogenic than mycophenolate, and mTOR inhibitors, on the contrary, may reduce the incidence of post-transplant neoplasia, even though the most convincing evidence is about skin cancer. Also, we should take into account that immunosuppression before transplantation, for example, for glomerulonephritis or vasculitis, can also be associated with post-transplant neoplasia. And also duration of dialysis before transplantation. We know that dialysis, being in dialysis, is associated with an increased risk of cancer, especially of the kidney, urinary tract, and thyroid, and that end-stage renal disease, due to the development of acquired cystic kidney disease, increases the risk of the development of malignancy in these organs that are senescent. Moving to pathogenesis, talking about the effects of immunosuppression, especially immunosuppression has some direct effects on the immune system because they decrease immune surveillance, and this increases automatically viral replication. For example, long-term immunosuppression reduces activity of natural killer cells that remove cancerous and precancerous cells in our body, and also the antigen presentation operated by dendritic cells. There is also an exhaustion of T cells, the so-called immunosenescence, that impairs viral immunity and predisposes to the development of tumor. And also in kidney transplant recipients, it has been observed an increase in the ratio of T regulatory cells in comparison with effector T cells. And this phenotype can predispose also to the development of cancer. Apart from this direct effect on the immune system, the immunosuppressant drugs can also have direct oncogenic effects. For example, calcineurin inhibitors, that are the most important class of drugs that we use in order to prevent rejection, well, they favor tumor progression, especially because they increase the expression of vascular endothelial growth factor that promotes angiogenesis of the tumor, and also they are associated with an increase in TGF-beta, and this is associated with an increase in the tumor growth. Also, they increase the RAS-RAF signaling, which is implicated in carcinogenesis in renal cell carcinoma, and also they increase interleukin-6 production that is associated with B-cell proliferation in PTLD. Azathioprine also impairs DNA mismatch repair proteins, and as you know, skin cancer is secondary to DNA damage caused by ultraviolet radiation. So especially azathioprine is associated with skin cancer. Moving to outcomes from this brilliant study and master case control study published in Transplantation from van der Wettering, we know that the median survival of kidney transplant recipient is much lower than the median survival of general population with neoplasia. And worst outcomes probably depend on the timing of clinical presentation. Probably this tumor, they make themselves clinically manifest after, and it seems also that tumor biology is more aggressive. We should take into account that in many cases patients are very delicate, are very fragile, and probably there is also a selection bias. There are some kidney transplant recipients with coexisting comorbidities that they cannot undergo intensive treatment, intensive chemotherapy and radiotherapy for cancer treatment. Outcomes are also age, sex, and tumor dependent, while all the recipients have a twofold greater relative risk of cancer-related death in comparison with age-matched population. the relative risk is much higher in younger recipients in comparison with age-matched population. And especially higher aggressivity is noted for PTLD, skin cancers, including Kaposi sarcoma, stomach and bladder cancer. In this brilliant review, published in 2021, you can see that mortality ratio is overall increased in both sexes, but this can vary according to the type of cancer. So, for example, it's much higher in melanoma, in lymphoma, for stomach cancer, especially for women, and for bladder cancer. Curiously, for big killers in the general population, such as lung and breast cancer, the mortality ratio is not so higher in comparison with general population. Moving to management, well, management depends on the type and severity of malignancy. And usually when a patient develops a cancer, we consider to decrease immunosuppression because as we have seen in the part regarding pathogenesis, immunosuppression is related to decreasing immune surveillance and to the promotion of the tumor growth. So it makes sense to decrease immunosuppression to fight cancer, but this must be weighed against the possibility of graft rejection. So different strategies can be employed, such as reducing immunosuppression to a 2-drug regimen by withdrawing the antiproliferative drug, for example, mycophenolate, and also we can consider switching to an mTOR inhibitor that is especially useful in the setting of skin cancer. The benefit of reducing immunosuppression depends on the type of cancer. So this it implies that if the pathogenesis of cancer is related to immunosuppression, it's most likely that reducing immunosuppression will increase the likelihood of treating the cancer. For example, in Kaposi sarcoma, withdrawal of CNI can lead to cancer disappearance in a substantial proportion of patients, while on the other hand, in cancers that are not related to immunosuppression and whose incidence is not different from general population, for example, breast and lung cancer, while reducing immunosuppression may not be beneficial. In the last years, new drugs have been developed and they have marked a difference for many patients with neoplasia, especially checkpoint inhibitors, including antiprogram DAT1, DAT ligand 1, and CTLA4. These drugs in the transplant setting, apart from increased T-cell activation against the tumor, they can break tolerance against alloantigens. So we should pay attention to the risk of developing also a rejection. This is a study published in 2019 in which liver transplantations and kidney transplant patients with metastatic cancers have been treated with these drugs, and we can see that in many cases, almost half of cases, rejection has developed, and in 21% of all patients, an ideal response was observed. That means anti-tumor response without graft rejection. However, we should take into account that all of these patients were metastatic patients. Moving to the last point, prevention. This is probably when we can mark a difference for our patients. This is a very nice figure from this review published in Nature in 2018. We can see, for example, that for skin and lip cancer, regular self-examination and physician or dermatology examination every 1 to 2 years is recommended. Breast cancer and cervical cancer, we should follow the guidelines for general population. While renal cancer screening is not recommended by most guidelines, but we can consider doing ultrasound in case of acquired cystic disease, familiarity, and long dialysis vintage. Colorectal cancer, we can do an annual or biennial fecal occult blood testing. And for example, for urothelial cancer, screening is not recommended, but we can consider it in patients who receive cyclophosphamide. Liver cancer, we can do alpha-fetoprotein and ultrasound in patients with cirrhosis. And lung cancer, in heavy smokers, we can consider low-dose CAT scan every 1 to 2 years as prevention. So this is all. Thank you very much for your attention and have a really nice working day.